Welcome to the deep dive. We take the info you need to know and, well, boil it down to the crucial bits fast.
That's the plan.
Today we're tackling a revision request, prolactinoma.
Yep, we've got your MSRA notes right here. And our mission, really, is to give you a clear, high-yield understanding of prolactinoma.
Making it stick.
Exactly. Think of this as your express route to confidently recalling the key facts. We'll throw in some handy memory tools along the way, too.
Okay, so let's kick things off. What exactly is a prolactinoma?
Right. So at its core, a prolactinoma is a non-cancerous growth. It sits on the pituitary gland.
The pituitary, okay.
And the big thing about it is that it makes the pituitary produce way too much prolactin.
Prolactin milk production.
That's what it's famous for, yeah, in breastfeeding women. But it's also involved in just general hormonal balance for everyone. And too much of it can really, well, disrupt that balance quite significantly.
Got it. So it's a specific type of pituitary adenoma, which is just a pituitary tumor.
Exactly, a specific type. Pituitary adenomas are generally benign, meaning non-cancerous, and prolactinomas are actually the most common type that secrete hormones.
And they come in different sizes.
They do. We categorize them by size. Microadenomas are small, under a centimeter.
Micro, under 1 centimeter.
Then you have macroadenomas, larger than a centimeter.
Macro, over 1 centimeter.
And then for a real whopper, we have what are called giant pituitary adenomas.
Yeah.
Anything over 4 centimeters.
4 centimeters. Wow. Giant.
Yeah. Think giant. That 4-centimeter mark is sort of key to remember. And just to put your mind at ease, cancerous prolactinomas, extremely rare. Really, really uncommon.
That's good to know. And I think I saw something about links to other conditions.
Yes. Sometimes there's an association with something called multiple endocrine neoplasia type 1, or MEN1, NE. NE1, it's a genetic thing. It affects several endocrine glands. So if someone has a prolactinoma, it might make doctors think, okay, should we check for potential issues in the parathyroid glands or the pancreas, too?
Right, because it's all connected.
Exactly. A good reminder that these hormone systems, they often talk to each other.
Okay, so we know the what. What about the why? What actually causes these things?
Yeah, that's the big unknown, unfortunately. We don't have a single definitive cause.
No clear trigger?
Not really. The main idea is that it probably starts with just one non-cancerous cell in the pituitary that goes a bit haywire, starts multiplying, and just churns out prolactin.
Right. But the notes also mentioned other reasons someone might have high prolactin. How do we tell those apart from an actual prolactinoma?
Ah, yes, that's absolutely critical for diagnosis.
Yeah.
You got to consider the natural physiological reasons first.
Right.
For pregnancy, obviously prolactin levels shoot right up then. Estrogen levels can also play a role. Even everyday things like stress, heavy exercise, even sleep can cause temporary bumps in prolactin.
Okay, so normal life stuff.
Pretty much. Then there are other medical conditions. Acromegaly, too much growth hormone, is actually seen in about 1/3 of prolactinoma patients. Suggests maybe some shared mechanism there.
There's
Polycystic ovarian syndrome, PCOS, that could be linked sometimes. And importantly, primary hypothyroidism.
low thyroid function. How does that link?
It's because when the thyroid is low, the body releases more TRH, thyrotrophin-releasing hormone, trying to boost it. But TRH also tells the pituitary to release prolactin.
Ah, like a 2-for-1 deal?
Kind of, yeah. So low thyroid can indirectly raise prolactin. Always check the thyroid function.
And medications. They can cause hyperprolactin too, can't they?
Definitely. A big one to remember, several drugs are known culprits. Common ones like metoclopramide and domperidone, used for nausea.
Okay.
Certain older antipsychotics, the phenothiazines and haloperidol, are also well known for this. Remembering those drug classes is really useful when you're taking a patient history.
Any others?
Less commonly, maybe some SSRI antidepressants, and occasionally opioids have been linked. So yeah, always check the medication list.
Okay, makes sense. Now, the notes highlighted female gender as a big risk factor.
Yes, definitely. Prolactinomas are diagnosed much more often in women, particularly before the menopause.
Why is that?
It's likely because the effects, like changes to their periods, are just more obvious and lead them to seek help sooner. We also see a higher risk in people with a family history of pituitary tumors, suggests a possible genetic element sometimes.
And the medications we just talked about.
Absolutely. Those medications, especially the ones that block dopamine, like some antipsychotics, increase the risk because dopamine normally acts like a brake on prolactin production. Take away the brake.
Yeah, and prolactin goes up.
Got it. So let's get into how this actually messes with the body, the pathophysiology. What's the chain reaction?
Okay, so the core issue is the tumor pumping out way too much prolactin. Simple as that.
Right.
This excess prolactin then throws off the balance of other hormones. The key ones it suppresses are estrogen and testosterone.
Okay, so it turns down the sex hormones.
Exactly. Think of prolactin as hitting the mute button on estrogen and testosterone production. And it's this hormonal imbalance that causes pretty much all the different symptoms people experience. Right, that clicks. So when a doctor is faced with high prolactin, what else might be causing it? The differential diagnosis.
Good question. As we touched on, drug-induced high prolactin is a major one to rule out first.
Check the meds.
Always.
Hmm.
Then hypothyroidism, like we said, because of that TRH link. Chronic kidney disease can also cause problems with prolactin clearance. And sometimes other types of pituitary tumors, even if they don't make prolactin themselves, can press on the pituitary stalk and interfere with dopamine getting there, causing a mild rise. It's called the stalk effect.
Stalk effect, right.
So yeah, it's about thinking through all the possibilities systematically.
Now, how common are these? What's the epidemiology look like?
It's interesting. We don't have absolutely precise UK-wide numbers, but estimates suggest prolactinomas make up a pretty big chunk, maybe around 40% of all pituitary tumors diagnosed here.
40%, okay.
The overall prevalence is maybe somewhere between 6 and 50 cases per 100,000 people. It varies.
And we said more common in women.
Yes. Diagnosed more often in premenopausal women, likely because symptoms like messed up periods get noticed.
Makes sense.
But here's a key point. Those giant prolactinomas, the ones over 4 centimeters, they're actually quite rare. Only about 2–3% of all prolactinomas. And interestingly, they tend to be more common in men.
Oh, okay. Giant ones more in men.
Seems so. And here's something that might surprise you. Prolactinomas are really quite uncommon in children. They only account for about 2% of all brain tumors in kids.
Only 2%. Yeah, that is surprising. Okay, so we know who's more likely to get them. What are the actual symptoms we need to look out for? Sounds like they're different for men and women.
They definitely are, mostly because of those estrogen and testosterone effects. In women, the hormonal changes often lead to irregular periods or periods stopping altogether. That's amenorrhea.
Right.
Infertility is another common problem. And, of course, galactorrhea, that milky discharge from the nipples when not breastfeeding.
Yeah.
That's a classic sign.
Galactorrhea, okay.
And because estrogen levels are low, women might also get symptoms like vaginal dryness, maybe reduced sex drive. If it goes on long enough, it can even lead to bone thinning, osteoporosis.
And what about men? What do they experience?
In men, it's mainly driven by the low testosterone. So decreased libido, erectile dysfunction are really common.
Okay.
They can get galactorrhea too, but it seems less frequent or maybe just less noticed. They might also have other signs of low testosterone, like feeling tired all the time, maybe some muscle weakness.
And you mentioned extra symptoms if it's a macroadenoma, the bigger ones.
Yes, exactly. When the tumor gets larger than 1 centimeter, it can start physically pressing on things nearby in the brain.
Like what?
Well, it can cause headaches, and it can press on the optic nerves, or more specifically, the optic chiasm where the nerves cross. This causes visual problems.
What kind of visual problems?
The classic visual field defect to remember is called bitemporal hemianopia.
Bitemporal hemianopia.
What does that mean? It means you lose the outer half of your vision in both eyes. Like wearing blinders, you can't see things off to the sides.
Ah, okay. Tunnel vision almost?
Sort of, yeah. Or sometimes it might just affect the upper outer parts and upper temporal quadrantenopia. And these big tumors can also squash the rest of the normal pituitary gland,
Leading to
hypopituitarism, where the pituitary can't produce enough of its other important hormones, causing a whole different set of problems.
Okay, quite a range of issues then. So if someone comes in with these kinds of symptoms, how do doctors figure out if it is a prolactinoma? Investigations.
The first step is usually a blood test, simple blood test to measure the serum prolactin level.
Check the prolactin.
Exactly. If it's significantly high and there aren't other obvious causes like pregnancy or certain drugs, it strongly points towards a prolactinoma.
But not always definitive. You mentioned the stalk effect.
Right. A mildly raised prolactin could be that stalk effect from a different type of tumor nearby. So the next absolutely crucial step is imaging.
An MRI.
Yep, an MRI scan of the pituitary gland. That lets us actually see the pituitary, see if there's a tumor, and measure how big it is.
So high prolactin plus an MRI showing a tumor usually seals the deal.
Pretty much. The diagnosis often really rests on finding that adenoma on the MRI in someone with the right symptoms and high prolactin levels.
Okay, diagnosis made. What's the management approach here in the UK?
The good news is that most prolactinomas respond really well to medication, specifically drugs called dopamine agonists.
Dopamine agonists, like what?
The main ones used are cabergoline and bromocriptine. They basically act like dopamine in the body.
And dopamine normally inhibits prolactin.
Exactly. So these drugs effectively tell the tumor cells to calm down and stop making so much prolactin.
Clever. How well do they work?
Very well, usually. They lower the prolactin levels in the blood, which helps with the symptoms. And importantly, they often cause the tumor itself to shrink.
Oh, they shrink the tumor too.
Yes, quite often. So we typically use them whenever the tumor size is causing problems, like visual issues, or when the high prolactin itself is causing symptoms like infertility or irregular periods.
Which drug is preferred?
Cabergoline is often the first choice these days. It lasts longer in the body, so you usually only need to take it once or twice a week, which is much more convenient for people long term. Bromocriptine needs to be taken more often.
Any downsides? Side effects?
Yeah, there can be side effects, things like nausea, dizziness, sometimes feeling sleepy. And one thing to be aware of, though it's rare, is the potential for impulse control problems, things like excessive gambling or shopping.
Really? Impulse control.
It's a recognized, though uncommon, side effect with dopamine agonists. Also, with long-term use, there's a very small risk of fibrosis, like thickening of heart valves, so sometimes monitoring like an echocardiogram might be needed, especially with higher doses. Quinagalide is another option, but pergolide isn't used in the UK anymore due to those heart valve concerns.
Okay. What if the drugs don't work well enough?
If the dopamine agonists aren't cutting it, maybe the prolactin stays high, or the tumor isn't shrinking, or the side effects are just too bad, then surgery becomes an option.
To remove the tumor.
To remove it, or at least reduce its size, usually done through the nose, a transsphenoidal approach.
And if surgery isn't possible or doesn't get it all?
Then rarely, radiotherapy might be considered. But that's usually a later option because it can have long-term side effects on the surrounding pituitary and brain tissue.
Gotcha. What about, say, a woman with a small prolactinoma, a microadenoma, who has low estrogen symptoms? Can she use hormone replacement or contraception?
That's a good point. If a woman has hypogonadism, the low estrogen from a microprolactinoma, and needs contraception, using an estrogen-containing contraceptive pill can sometimes be considered. But it needs to be done cautiously, with regular monitoring of prolactin levels and maybe MRI scans.
Because estrogen can make it grow.
There's a small theoretical risk, yes. Though generally for microadenomas, the risk of significant growth triggered by estrogen seems quite low. But monitoring is definitely key.
And pregnancy, that must complicate things.
It can. During pregnancy, the normal pituitary gland naturally enlarges, and prolactinomas can sometimes grow a bit too, especially the macroadenomas.
So what needs to be done?
Women with macroadenomas need careful monitoring during pregnancy. They need to be aware that any new or worsening headaches or visual changes could signal tumor growth and need urgent assessment.
Do they stay on the dopamine agonists?
Ideally, we try to stop the dopamine agonist during pregnancy and breastfeeding if it's safe to do so, particularly if it's a microadenoma that wasn't causing pressure symptoms beforehand.
Is it safe if they do need the medication?
If treatment is necessary during pregnancy, perhaps for a large macroadenoma causing problems, then both bromocriptine and cabergoline seem relatively safe. Bromocriptine has been around longer, so there's more safety data, and it's often the preferred choice if medication is essential during pregnancy.
Okay. So overall, what's the general outlook for someone diagnosed with prolactinoma, the prognosis?
Generally, it's very good, really favorable. With the right management, usually the dopamine agonists, we can get excellent control of the prolactin levels and the symptoms,
And the tumor shrinks.
and often achieve significant shrinkage of the tumor itself. It is usually a chronic condition, though. So long-term treatment and regular follow-up monitoring are typically needed.
Right. It's not usually a cure, but managed long-term.
Exactly. Managed effectively long-term.
What about complications? What are the main risks if it's not managed well?
Well, the main ones stem from the hormonal effects. So infertility, sexual dysfunction, low libido, ED. Osteoporosis is a risk from long-standing low estrogen or testosterone.
And the tumor size?
Yep, the larger tumors, the macroadenomas, can cause those compression problems, headaches, the visual field defects we talked about, and potentially damaging the rest of the pituitary gland, leading to hypopituitarism.
Anything else?
Very rarely, prolactinomas can behave more aggressively and invade nearby tissues, but that's really uncommon. For the vast majority, it's a benign tumor.
Okay, this has been a really comprehensive deep dive. For anyone revising, let's recap the absolute must-knows. Prolactinoma. It's a benign pituitary tumor
Absolutely benign, yeah.
causing too much prolactin. This messes up other hormones, especially estrogen and testosterone, leading to different symptoms in men and women, plus maybe galactorrhea.
Don't forget the macroadenoma symptoms: headache, visual field loss, especially that bitemporal hemianopia.
Right. Diagnosis relies on high serum prolactin levels and seeing the tumor on an MRI.
Crucial steps. And always rule out drugs in hypothyroidism.
And the main treatment.
Dopamine agonists,
Oh, great.
cabergoline or bromocriptine. They lower prolactin and shrink the tumor in most cases. Surgery or radiotherapy are options if drugs fail or aren't tolerated.
Prognosis is generally good with management, but it's often long-term.
That's the gist of it. And perhaps the final thought to leave you with.
Mm.
Prolactinomas are such a clear illustration of how incredibly delicate the endocrine system's balance is.
How one little thing.
Exactly. How one small, usually non-cancerous tumor overproducing just one hormone can have such far-reaching effects on fertility, sexual function, bone health, even vision. It really highlights the intricate connections. Maybe something to ponder is just how many other subtle hormonal interactions are going on that we don't even notice until something goes wrong.
But that's a great point. The body's complexity is amazing. Hopefully this deep dive has really helped solidify prolactinoma for your revision.
We hope so.
For more resources, practice questions, and MSRA support, definitely check out pastthemsra.com.
And don't forget freemsra.com for loads of free questions too.
Keep up the fantastic work with your studies, and we'll catch you on the next deep dive.